Hello everyone, my name is Trevor Cox and I am excited to share this week's patient presentation with you guys. This patient is a 42-year-old male, height of 6'1", weight of 136 pounds, and a BMI of 18, signifying that this patient is underweight. Usual body weight was not given, however his ideal body weight is 80 kilograms or 176 pounds. The length of stay is 1 day. The weight trend that we have seen since admission was a loss of 14 pounds or 10% in the past 24 hours. His admission weight was 150 pounds. He is now currently 136 pounds. I will get into this later. However, a quick synopsis of this is due to his NPO status and his persistent vomiting. However, he was also and currently admitted for a DKA associated with type 1 diabetes mellitus. Moving right into his medical history, he has a primary diagnosis of trigger finger, DKA, hypertension, hyperlipidemia, alcohol abuse, bipolar disorder, gastroesophageal reflux disease, type 1 diabetes mellitus, hypothyroidism, and metabolic acidosis. And this can be seen in the lab values later in the presentation. And nothing really to note on the secondary diagnosis or the past hospital admissions, just that he has had past surgeries to get removed from the arm, and also he's had a hand surgery. Moving into his lab values, he does have quite a few abnormal lab values, as he does have a lot of different diagnoses going on at this moment. He does have low sodium, which would signify hyponatremia. He also has a very low CO2 of 18, which signifies the respiratory and metabolic acidosis as stated previously. Also, his BUN and creatinine are elevated, and while he is not on dialysis and does not have any type of kidney diagnosis or distress, we would signify after speaking with my preceptor this would be pre-dialysis, and we should be monitoring these values. Also seeing the calcium is low, hypocalcemia, and he also has a high glucose of 203, and this is due to his type 1 diabetes, and also a high hemoglobin A1C of 8.6. Looking now at the medications and treatment, he is on medication for his hypothyroidism. He also does have a history of opioid abuse, so he is on a medication for that to regulate the hormones and chemical balance within the brain and throughout the body. He is also on an insulin drip to regulate his type 1 diabetes, also medication to treat his hypertension. He's also on a PPI to decrease his gastric acid output, as he has reported to the physician that he has been having persistent vomiting and throwing up in the past 24 hours. So that is what the PPI is for in this case, and is also the reason that he is NPO at this moment. And he is also on medication for high cholesterol and also for hypokalemia. So moving into the nutrition assessment, this evaluation was consulted due to the MD, and as said previously, this was due to the DKA associated with the type 1 diabetes mellitus. The patient was admitted on the same day that we saw them. The length of stay was 1 day. The patient is currently NPO day 1 due to persistent nausea and vomiting for the past 24 hours. He is NPO as stated. However, the goal diet is a consistent carbohydrate and cardiac diet. Now moving into his estimated energy needs. We did use the Mifflin St. Jeor to calculate his needs and use a stress level and activity level of 1.2, giving us a low energy needs of 1,547 kcals for low energy needs, and high energy needs were 1,857 kcals. His protein range was 1.0 to 1.2 grams per kilogram, giving us a value of 62 to 74 grams. And we did use his actual body weight in this calculation using the Mifflin St. Jeor. And his fluid is just 1 ml per kg. And with all that said, moving into the PES statement, I created the following: inadequate energy intake related to increased energy requirements due to a pathological cause, as evidenced by the DKA and BMI of 18. Moving now into the nutrition intervention, the following is what we created: food and nutrient delivery, looking at meals and snacks of a modified composition. The modified composition in this case is for his diabetes and also his hypertension and some other cardiometabolic issues that he is experiencing at this moment. And as we move into increasing his oral intake, we're going to look at nutrition supplement therapy of Glucerna BID or twice a day. We will be monitoring and evaluating his biochemical labs and data, his nutrition-related medications, looking at his fluid intake, as this is the only intake that he's having orally at this moment as he's NPO, and also monitoring procedures and medical tests. And lastly, I compiled a plan of action. This is always easy and very useful for me to look at, so I thought it'd be useful to use in this presentation to kind of summarize all the data and what we collected, and kind of looking at the PS statement to get this information. So we are recommending to initiate nutrition support if patient is NPO for longer than 3 days, and this will be in the form of enteral nutrition in the form of Glucerna. The goal oral nutrition supplement is Glucerna BID. His goal diet is consistent carbohydrate and cardiac diet. And we are also recommending nutrition education and referral to outpatient nutrition program because of his uncontrolled diabetes. And the goal is to tolerate above 50% of estimated energy needs once he is taken off of the NPO diet. Thank you for everyone's time to listen to this presentation. I hope that you enjoyed it, and everyone has a great day.